Welcome to One Talk, brought to you by Sansom Diabetes Research Institute. I'm your host, Katie Hawk, and on this show, we discuss living with diabetes and bring in experts in the field to talk about topics related to type 1, type 2, gestational diabetes, and pre-diabetes. We do this to bring the diabetes community together as one. Be sure to like and subscribe so you don't miss any of our upcoming episodes, and in the comments below, let us know how we're doing. We want to hear from you. Thanks for watching. This week's episode is going to take a different format than our normal episode. We had the pleasure of having Dr. Steve Edelman speak at one of our type 1 outreach support groups, also called One Talk, and he spoke on type 1 diabetes, the past, present, and future. And it was just such an excellent presentation that we couldn't help but want to share it with you all. We have the whole presentation filmed, so please enjoy. Thanks for watching.
My daughter lives up here, and she works up here, and she's here tonight. And what better excuse to come to Santa Barbara, because I love the area here. So, and I've done the Sansom Clinic for a long time. I was good friends with Lois Jovanovic for decades. You know, what a great lady she really is. To me, was the Sansom Research Institute for so many years. And I know several other people there as well. I'm blanking on the guy with the British accent. David Kerr, gosh, I know him. I've been in a lot of meetings with him, and that accent makes him sound so smart. Okay, what I'd like to do today is give kind of a fun lecture, but it has a lot of information in there, and I know it goes to 7:30 tonight, but I definitely won't be speaking that long. If there's a question, you know, there should be plenty of time for questions. But if you have a burning question, just try to get my attention. So I'm going to talk about the past, the present, and the future, you know, of course, focusing in on type 1 diabetes. Okay. So I tried to pick a TV show that represents the past, the present, and future. So I picked Game of Thrones. Anybody here not see the Game of Thrones? Really? You guys have noticed? All right, well, it was in the past. So, you know, I think this is probably the oldest slide in anybody's slide deck. But, you know, this is, you know, when you think about the discovery of insulin, it's one of the best medical discoveries of all time. I'd like to show this slide because to this day there's crazy supplements with false promises. Even a stem cell, you know, replacement of the pancreas just rips off so many people. Even in the United States, they have centers that promise this stuff. And this is a very old slide of a picture of safe diabetes remedies. And I like to put that up. And look at this one. Down here it says 4 to 12 tablets a day until all diabetic symptoms disappear. So this is before the discovery of insulin. And that's probably one of my big pet peeves is the crazy marketing of some of these false claims, supplements, and different therapies. Some of you remember there was these centers that you had hepatic activation when you went to a center. It was started by Tom Aoki and UC Davis, and they finally were prosecuted and closed down. They pretty much opened up under different names. So this is way back March 22nd, 1922, when you know, two of the gentlemen who got the Nobel Prize, well, all four from Toronto, and that's the newspaper when they announced that they're coming close. This is Frederick Banting and Charles Best, and then there was Marjorie the dog. The dog is really cute, but what they did was they thought the pancreas had something to do with diabetes. So they took out Marjorie's pancreas, and Marjorie started drinking a lot, urinating a lot, and they noticed that ants were attracted to the urine. And so Best, the grad student right here, in his journals, he said he would take his finger and dip it in and taste it. It was sweet. And that was sort of their way of figuring out the pancreas had something to do with type 1 diabetes. Now, I love dogs very much, but what happened was the animal rights folks, they almost stopped Banting and Best from doing dog research. And this is how they did the cartoons. So for all of you animal rights people for research, if it wasn't for dog research, we would not have a cure for type 2 diabetes. So I went to UC Davis Medical School. We had dog lab. You know, I've been treating them respectfully. is the best way to go. So unfortunately, we have to test animals before humans. So this is Ted Ryder. He's 5, you see, he's 1923. He's actually one of the first kids ever to receive insulin. And you can see he's scrawny, skinny.
Steve, we can hear you in the back. Would you mind talking a little bit louder?
Oh, okay.
Thank you.
No problem.
Sorry to interrupt.
Okay. I thought maybe you're calling me speak louder. Okay, this is my other daughter calling me. Okay. Okay, I'll try to talk louder. Usually people tell me I got to talk softer. So, yeah. So he was one of the first kids ever to receive insulin, and he's scrawny, he's pretty skinny, and he's not very happy. And I usually say, if I had to wear that outfit, I wouldn't do that. The amazing thing, this is the first recorded logbook that we know of. This is his urine test. And you can see what's written right here is when he received an injection. And you can see the glucose went down in his urine, went down here, and then they realized that, the pancreas, and these were crude pancreatic extracts. They just took the pancreas, they put it in an osterizer. I don't think they had osterizers back then. And they gave the injection. And these people who got it, these kids, got these huge welts and abscesses because, you don't really inject that kind of stuff. You had a lot of, antibody response. And that was the beginning. And then this is Ted Ryder, 5 months after starting insulin. And, he certainly looks a lot healthier. And I think the thing that's amazing, this is, he lived to the age of 75. A lot of people think that's his wife. No, it's his mom. We always say she's the type 3 mom.
Wow.
At Taking Control of Your Diabetes, some of you know the organization that I run. We call the significant other type 3. So, you don't have diabetes, but you're the mother, the brother, things like that. Now, I know there's another type 3, so, but that's our definition. I think the success of anybody in type 1 is having a good partner. That's for sure. So these 4 gentlemen won the Nobel Prize, and what you can see up here is they have broad diabetes of its terror. So it's a pretty interesting story. There's a PBS movie called Enough Glory for All, and these guys really got in literally fist fights fighting about who should get credit for discovery. So I got diabetes when I was 15, 1970. And people say, oh, that's you, Steve, right here. No. That's Spanky. I worked at the Griffith Park Boys Camp. And that's when I first got diabetes. All kinds of stories about, I'll tell you later about the pissing contest. But I won it. Because I was out of control at that time. Now, the thing that's amazing, the reason why I put this up here, I always wonder what was wrong with this kid. 48 years after the discovery of insulin, almost 50 years later, the therapy that I was put on was the same, which was basically urine testing and 1 shot a day. So my doctor at the time really didn't know anything about diabetes. I was on 1 shot of NPH in regular day, once in the morning. For those of you that know about the length and duration of these insulins, I mean, NPH once a day and regular with once a day, but I ate 3 times a day. And I thought it's always interesting, look at the size of this needle. This was taken from my education book I got when I was 15 years old. And I was in a room of about 35 overweight folks with type 2. So I was 15, and I was sitting in this room, and the education was exactly the same. And then there was the diet. And the diet right here, like I said, it's circlet, but I always thought this is amazing. Look what they recommended. Big slab of steak with a layer of lard, whole milk, Wonder Bread, eggs, and green beans, and apple. And, if you think about it, it's not that bad. You have high cholesterol. But, and then this was the form of exercise. And if you were type 2, you basically only had 1 type of pill, the sulfonylurea. So the therapy and the education and the approach was the same. And type 1s are not the same as type 2s. I mean, we do share some things, but it is a completely different condition. So that was my urine test kit right here. And for some of you old timers, I don't know if you have any here. These were acetone and glucose tablets. You put 1 tablet in here, 10 drops water, 5 drops urine, and then you would drop, I can't remember, this is the glucose, it would turn all kinds of colors. It turned about 1,000 degrees too. And then you held it up to a color chart. And I remember the darker it is, the more sugar in your urine. But remember, whatever sugar's in your urine was in your blood 2 to 3 hours ago. So you never did any adjusting of insulin. You just tested it for your caregiver. Yeah, and you were on a super strict diet. And, my mother, God bless her, she's 90 years old, going to see her tomorrow in LA. She weighed everything out for me in the beginning, and then after a while that got pretty old, of course. And, if you can think about this, there was no pumps, pens, analog insulins. There was no A1C test. So your doctor couldn't just get a blood test and see how your control has been. Of course, there was no continuous glucose monitoring, no apps. So it really was the dark ages. So you take someone like Ted Ryder, who lived most of his diabetic life without all this stuff, did pretty darn well. And I know a lot of people that come to our conferences who have had type 1 for quite a long period of time, 50, 60 years, they're doing excellent. So, the new tools are quite helpful, but it depends how much effort you put into it. I think all of you can probably relate to that. And I went to UCLA as an undergrad, and I like to put up the slide because at that time, I didn't know anybody with type 1. There was no social media, and some of you may be familiar with the College Diabetes Network run by Christina Roth. It's really a great organization to hook in kids who are at college and help them with their diabetes. And I remember this is one of the education posters. And so this was it. And I'm looking at this thing as a kid, stroke, blindness, heart attack. So that's controlled on this side and uncontrolled this side. And I'm in the back of the room and I see that it says, I look over here and I didn't know what that was for. Important. At first I thought I said importance. I said, you're damn right it's important. And then I looked at it closer, so I said, I better get my control improved. So the last thing, I think I have a couple more things on the past is, you didn't see the show, but this is the I'm not supposed to say midget, that's not that one. But he's a great actor, by the way. So he's a midget on the Game of Thrones. But back in those days, if you had really poor control before puberty, probably happens today too, then it really stunted your growth. So I think that's something that we don't see as much of. But there's plenty of areas of the world where they don't have good care, they don't have access. I was in Rwanda a couple years ago on a humanitarian mission, and these poor kids, they only get to test their blood sugar with a meter once a month. And they have no refrigerators, and they have terrible complications. And by the way, today's World Diabetes Day, right? My saying is, I think every day should be World Diabetes Day. We need to focus on this every day. And I know it's a day to highlight it for sure. This is a patient of mine, Cindy Fina. She made it on the cover of Diabetes Forecast. That's no small thing. She's a CDE. She's also a dental hygienist and a belly dancer. So she was very active in the world, and she was in charge of the volunteers at Taking Control of Diabetes. She was just an awesome person, and unfortunately, there's her at one of our conferences in San Diego. She passed away from hypoglycemia. She lived alone, she was divorced, neighbor knocked on the door and they noticed the blinds weren't up, and she had hypo-unawareness, and she had several hypoglycemic reactions, and she a couple seizures, car accidents, and no matter what I told her, she, you gotta back off, when you've been drilled your whole life, get your blood sugars down, otherwise you're going to get complications. You can't just say, okay, I'll let my blood sugars run high. And so this situation has changed a lot with continuous glucose monitoring tremendously. Now, what was also sort of right near the present time, now that we don't have to calibrate our CGMs, it's kind of at the end of the past before the present. Home glucose monitoring was probably one of the biggest advances ever in the early 1980s. I remember I was in medical school at UC Davis, and it was like an amazing thing that you could prick your finger. Some of the older meters, it took you a minute just to wipe off the blood. And I remember the doctor saying, the endocrinologist saying, oh, that's going to be way too much information for our patients. Let's go against this. Same thing happened with CGM. If you want to get me going on that, we start talking about that. But there's a lot of good meters out there. But one thing that bugs me, all these meter companies, look at their advertisements. And I always say I dare them to come up with an ad. And they should have little sayings that come out. If you're above 200, like son of a any kids here? Son of a bitch, or and maybe a little song that would come out that would be like, you can pick your own song. So this was the first insulin. This guy has type 1. How many of you have not seen this slide? This is probably the oldest slide. A couple of people. Good. This is a guy. This is the first insulin pump. And batteries last about 20 minutes. And he had type 1. He was an engineer, and and of course they've come a long way for sure. And back then, this is an absolutely true slide. The best way to control type 1 diabetes: stand perfectly still, do not eat, and do not exercise. And if your basal rate is set, you're just going to be perfect. That's really true. The problem is, you have to eat, and we push exercise. I think type 1 diabetes is probably the only condition I know of where exercise will really mess you up. And so even if you're a type 2, you can exercise for an hour, your blood sugar will come down a whole 20 points. Like it would be, and I don't want to make fun of type 2s, which I don't do. But I have a colleague that does, and we kind of make jokes about it. But that's really it. And we have so many more things going on now. And I mentioned earlier, there's a lot of differences between type 1s and type 2s. A ton. Everything from misperceptions and physical appearance all the way down to the theme song, which I'll play in a second. The incidence and hereditary influences, the causes and prevention strategies, associated conditions, and treatment options. We're sharing a lot of the treatment options these days. And if you think about it, with type 2, I do a lot of type 2, I've done a lot of type 2 research in my day, that we have no clue what causes type 2. It's a genetic condition, it's a heterogeneous defect of intracellular glucose metabolism. I know I impressed you with that sentence. I practiced it so many times. But we can prevent it. There's the diabetes prevention program, which I was involved with, several other prevention trials. So, and what is the prevention of type 2? You just take what we usually treat for people with type 2 and just give it to them early. So it's not real fancy, but it works as long as you take the medication. You're not curing anything, you're just preventing it. The minute you stop it, typically patients become hyperglycemic again. Now with type 1, we know a lot about what causes type 1, unlike type 2. It's an autoimmune process. Killer T cells, they go awry. We don't know why people develop these autoantibodies, but we do know that's the cause of type 1. Yet, do we have any prevention strategies? Zero. After years and years of research, we have cured so many rat, animal, and rabbit models. Even the ViaCyte project, with encapsulated beta cell, total flop. And there's a whole bunch of reasons for that. I give them credit for trying, but we don't, they did animal studies way too early, and they did animal studies, they went to humans too early. But we really haven't had any significant studies. Now, there was one within the last year, but I'll tell you about that when we get to the future. Now, The other thing is, I want to tell you about the theme song. And this was the theme song for people with type 1. People ask me all the time, what's worse, type 1 or type 2? I said, it's like adult diapers, it depends. Because you can have type 2 and end up with so many complications if your controls are good. And you can be type 1 with good control and live longer than your age, weight, and sex match controls. Now, the other thing that was in the past was the traditional education approach. And unfortunately, it's still this way today. And I want to tell you how I got going with taking control of your diabetes. You know, we have the research and teaching institutions. They come up with something important, then they educate healthcare professionals, and it takes them about 10 years to change their practice habits. And then they take those advances and they institute them in their patients. But this is extremely slow going, like really slow going. You talk to any pharmaceutical rep, and my daughter told me today, she called on the doctor and he goes, GLP-1, what's that? You know, and not because that doctor's stupid, but they're stuck in the trenches, they don't have time to keep up, they haven't been trained in that area, and that they've only been out 15 years. So one day, literally, I was in the shower, that's not me, and I had this idea, and to take the important messages about living a long and healthy life directly to the people most affected. And that was sort of the birth of Taking Control of Your Diabetes. And September 23rd, 1995 was the very first patient conference. And in October 12th of this year, just last month, we had our 25th annual conference. And we put them on around the country as well. So if you go to our website, we have our 2020 schedule up. We go everywhere across the United States, including Honolulu. Someone's got to do it. So here's my two kids, Karina. See if you recognize her in the room. Her older sister, Talia. I moved to San Diego from training at the Joslin Clinic. And believe it or not, I've been on faculty at UCSD and the VA for 32 years. And I say the veterans, they gave me PTSD working with them. And it's a point that we have to really change the way we educate healthcare professionals. And Earl Hirsch from Seattle, many of you know him, he has type 1, he's an endocrinologist. He figured out that like 4% of medical school is taught on education of diabetes. Yet when you get out as a doctor, at least 25% of your patients are going to have diabetes, whether they're there for your particular specialty or not. So, you know, this is a slide I use at the patient conferences, you know, typically at the end of my talk, you know, why is taking control of your diabetes so important? Well, every person with diabetes needs to be the most active member of this healthcare team. You know, I always say the same thing. You have the main responsibility of taking control of your diabetes. You are your own best advocate, and be smart and be persistent. You know, help your doctor take better care of you. And I do think we need more patient education. You know, TCOID can't do it all. Sherry Colberg, who's somewhere in this room, she was the co-director, and she was in Virginia on faculty there. She's retired here in San Diego, famous exercise specialist. So this is a much better way to improve diabetes care at a community level, is to educate both the healthcare professionals and the people with diabetes in kind of a parallel fashion, and then create communication between doctor, patient, doctor. You recognize Bill Polonsky? He spoke up here a few months ago. He's a good friend of mine. He's Mr. Touchy-feely guy. He's a clinical psychologist. Okay, we're up to present. We're making good time here. And how many people here have not watched the Breaking Bad series? That's one of the best series. Do you have a television? She doesn't want to live her life. I don't either, but I do. Watch it on my treadmill. You know what? Yeah, it's on Netflix. It's an excellent series. Really good acting. You know, that's Brian. Yeah, Brian Cranston. Vince Gilligan or Gilligan. He's the director. It was really great. So I picked that one for the present. So let's talk about type 1 diabetes, right now. And the bottom line, diabetes is still up. Here it is. Here's what I say about diabetes. Hold on, it didn't go, but I'm going to do it right now.
I need you like bitch.
You have to know the show. Jesse is one of the main characters, and there's a whole compilation of him. He uses that word quite a bit. And I think for a lot of people, diabetes is still difficult. And this slide takes me through some of the unmet needs that I think are important. I think this is probably number one, unpredictable glucose swings. CGM is here, it helps. Unfortunately, only about 30% of type 1s in the United States have a CGM. And you look at the average A1C of type 1s, they go to the best centers, it's about, only about less than 30% end up with an A1C less than 7. But I'm going to talk about that. Not enough time and range. It's sort of the same thing. Time and range defined as the percent of time between that your blood sugars are between 70 and 180, and reaching your A1C goal without hypo. All three of those are related to variability, if you think about it. And preventing and controlling weight gain. Everyone gains weight as you get older, so do people with type 1 diabetes. Type 1 diabetes weight leads to the development of cardiovascular risk factors. I used to say for years, just about type 2. It's the number one cause of death for people with type 2. They have high blood pressure, abnormal cholesterol, hypercoagulable state, all this stuff. But it turns out that the most common cause of passing away in type 1 is heart disease. Now, I should say that the most common cause of passing away anybody on this planet is heart disease. So, it's not like we're getting picked on, and of course, the whole emotional burden. I got some patients who have learned to adapt. They have no problems with that. They have good support system. And of course, everyone's brain is a little bit different. And then you talk to Bill Plonsky, who deals with this all the time. And some people deal with it better than others. That's the bottom line. I believe this lecture is being filmed, so in case you want to watch it later. So this is from the T1D exchange, and this shows the percent of patients who have an A1C less than 7. So you take these younger kids, you can see they're doing pretty well, but they changed the goal. Less than 9%, less than 8%. Here are 13 to 20. And I think you got to start from somewhere. And there's a whole bunch of reasons for this particular individual, but getting the CGM is the first step, and then slowly trying to improve things. You can't improve things overnight. Here's another one, and I like to show this one. This person's also pretty messed up. Look at where they set their alerts.
They didn't want to.
Yes.
And if you put your high alert this high, it defeats the purpose of wearing the CGM. Now, I understand if you're someone with a not very good control, and your doctor puts on their 70 to 180, you're going to get alarm fatigue big time, and so there's a whole approach to that. But trying to get a patient or someone to say, hey, I think that's too high, I'm going to lower it myself. I mean, that's music to my ears. You can't just force them because it's not going to work. The significant other is going crazy. They can't sleep at night. And so, it's not that you can just slap a CGM on someone, they're going to do well. And the significant other is pretty important in this whole picture, too. This is an old download, but when someone says to me, what is having type 1 diabetes like, I show them this picture. it is unpredictable swings. And this is obviously 7 days overlap on each other. If I saw someone like this, I'd say, you know what we got to do? We got to really make sure your basal rate is set correctly. because if you don't have your basal rate set, whether you're on a pump or an injection, it makes everything else tougher to adjust. And I think this is really true. So many people are frustrated because, they have these unexpected highs and lows. We give patients these very strict insulin to carb ratio, sensitivity factor. These are so gross, calculations. They really don't work half the time, and there's so many variables that can make these things go awry. Not responding to insulin, to consistency or exercise, and that's why CGM is so important. And just remember that when we all inject insulin, it's in the subcutaneous tissue, and all bets are off if you're going to get a consistent time course of action. Even injecting in the same location at the same day, you might have different time course of onset, peak, duration, and there's so many variables, even seasonal variables, temperature variables, things like that. I had a patient today. I talked to him in the car on the way up, and he says to me he's having all kinds of issues with how his insulin sensitivity. It goes from like 50 to 100. Like 1 unit brings you down 100 points, and then he tells me he leaves the insulin in his pump. He has a tandem for like 6-7 days without changing it. Your insulin starts to denature after 3, and that's one of the issues. So let's talk about CGM. I think the G6 is really amazing device. No more finger sticks. I mean, that's hard to believe. Someone said to me, "How do you know it's accurate?" No, I said to them, I didn't test it. I haven't tested for 6 months. They say, "How do you know it's accurate?" I said, "I don't know. I have no idea." But I have never had an issue where I got low and my thing did not say I was low. That's good enough for me. And of course, you can calibrate it, and I know you can go to the watch and iPhone, and I actually use the monitor as well. I have it on my phone, but I find that if I take out my phone too much in meetings, it looks rude. And even when I bolus with my looping, I say, "Excuse me, I need to give myself a bolus." My younger daughter, Karina, the way she used to text at the dinner table was unbelievable. So I'm always cognizant of that. So there's a new CGM out there. I really like this device, and it's an implantable CGM. And this little device goes under the skin. It's about a 5 or 10 minutes to put it in, probably about 15 to 20 between sterilizing and you put a steri strip over it, and it only works if you have this transmitter taped on it. Now, people say, "Well, gee, doesn't that defeat the purpose?" Well, to have an entire device with a power source, you'd have to have this huge thing implanted in the skin. And this is a very light, and it goes on this reverse tape. And it allows people to just put it on get a new one every 90 days. The company in Europe, it's approved for 180. So we're doing the study in the US. And I think 180 days is a really nice period of time. And then this transmitter sends it to an iPhone or an Apple Watch. So it's just a different model. I think it's a patient choice. Some people like to go in the water a lot and they don't have to worry about the tape coming off and things like that. And so it also goes to the Apple Watch. It can go to 2 different types of cell phones. In the Dexcom and the Eversense are the only 2 where you can share. I'll talk about the Libre in a second, which doesn't share, and the Medtronic, which doesn't either, but it doesn't have Bluetooth. And so it's kind of nice, depending, who your partner is. And I did this little video clip. I have these things on our website, the Edelman report, and this is just a clip. And I did a little thing with Bill about for all you type 3s out there to be knowledgeable how to handle the privilege of sharing the numbers.
These days are going to the cloud. Oops. Looks like a little giveaway. Well, it's so nice to catch these things early. Let's get some juice. Oh, whoops. Wrong that's Martinelli's apple juice.
Oh my God, Steve, I just got the alert. You're low, oh my God. I brought you Diet Coke, me down, insulin, and some stuff, and I can get you some more stuff, but come on. You're low, come on.
It's about 3 or 4 minutes. and then Bill and I are sitting, and he gives the significant other lots of good tips. And so this is, so I mentioned my friend Jeremy Pettis, who's a really good endo, and that's my name. He follows me. So one day, if you know what it looks like on your phone, this is what it looks like on your cell phone when you're following somebody. He takes a snapshot, and I was having kind of an up and down day, and he texts me. You see? How many people here use the Libre for your type 1? You have type 1? Not smart. The main issue is this. If it works for you, fine. I have patients with type 1. But there's no alerts and alarms, and there's no sharing features. So you may not want the sharing features, but to me, if I cross the 180, I want to know right away. The 2.0 will be helpful. You know about the 2.0? They're waiting to get approved at the FDA. You're going to get an alert when you cross your upper or your lower limit. So you'll say, okay, it's telling me I better scan. And so I don't really prescribe it for type 1s. I do have people that love it. So just saying.
And isn't it much more affordable?
Much more affordable. It is. Definitely much more affordable. Easier to get, too. You get it right from the pharmacy. But I'm just talking about the pure value of it. You're right. It is much. And I think with the 2.0, it'll be helpful. Oh, way better than that. Are you kidding? So the Medtronic one just doesn't work very good. It's their standalone. The sensor just sucks, period. And all I can say is if a doctor pushes on you, get a new doctor. That's all I have to say about that. So diabetes is not a rare disease. It's not an inexpensive disease. You know, look at all this technology. You know, it's expensive. CGM. You know, then we have, you know, we'll talk a little bit about pumps, and then the newer insulins. And I talk to healthcare executives all the time, trying to convince them that, you know, short-term control saves you tons of money. You know, absenteeism, presenteeism, you know, hospitalizations, length of stay in the hospitalizations, the cost per day in the hospital. Bill Polonsky and I published probably one of my favorite articles. It's called The Elusive Nature of Glycemic Control. Why do clinical trial results disappear in the real world? It's, you know, money's one thing, but there are lots of other issues as well. This is the gesture I like to give and still get away with it, show a kid with diabetes. Now, kind of switching to other present-day ways we can improve our control. This is probably one of the most important things I can mention is pre-bolusing. You know, if you can remember, to pre-bolus, and you can see what in this study that it was a big group of type 1s, all got the same meal, the same insulin per carbs, and these two groups took their insulin at the start of the meal or 20 minutes later, and you can see they peak right here. This group right here took their insulin 20 minutes before eating. So a couple caveats. One is was that a question? Oh, you're just scratching your head, sorry. And they start off with a pretty good blood sugar. So we know that if you start off higher, you should really wait longer until your blood sugars start to drop before you start eating a bunch of nutrients. But the other thing I thought was really interesting, these folks peaked out about 225. Now, if I was testing my blood sugar and I didn't have any trend arrows, even if the trend arrow was straight across, I might give myself 2 or 3 units. But they all ended up coming down here. So if I did it then, I would probably get low. You see, so pre-bolusing, you know, we always talk about controlling the spike after eating, and that's one of the most important ways you can do it, if you can remember. And I tell people, you know, even if you don't, they'll say, well, gee, I don't know how much I'm going to eat or what I'm going to eat. But most people know about how much they're going to take. At least take half of it right away. And the worst case scenario is you have to take a little bit more later on. And what about protein and fat? This is another area that's I'm interested in, you know, because we now just bolus based on the carbs and what your blood sugar is. But people don't realize protein and fat will raise your blood sugar totally. And this is a good study that I'd like to show, but I don't know what happened to part of it. you can't see it, but let me just describe it to you. A bunch of type 1s ate 4 meals, same carbohydrates, same insulin dose. This group, it had the same carbs, protein, and fat. This is just the same carbs only, very little protein and fat, and this is just a mixture. And what you can see on this slide is that this group just stayed high. So protein and fat will raise your blood sugar. It just takes a little longer. And if you read online, there are different formulas of how to figure this out. You know, it gets way too complicated. Insulin to carb ratio, insulin to protein ratio, insulin to fat. You know, it's impossible. But I think it's important to know that. If you have a pump, you can do extended bolus. If you're on multiple daily injections, you may have to give yourself a follow-on dose, same with inhaled insulin. So that's another thing I want to tell people, because they usually underdose for meals that have a lot of protein and fat. Okay. So, yeah, and then that's basically it. So, now in terms of multiple daily injections, I think most of you know that 75% of people with type 1 are on multiple daily injections. And now we have much better basal insulins and fast-acting insulin. So inhaled insulin, Afrezza, works unbelievable. It's probably the single best way to prevent a spike because it works within 10 minutes. Every time I let a patient try it, I'd say at least 8 out of 10 love it, and it's changed their control tremendously. Not using it only, in addition to their other insulin, depending on if they're just using it for correction or they're using it so they don't spike up after a high carbohydrate meal. And so I use it also with my regimen. Now, the other thing, I have a couple of slides on Toujeo and Tresiba. These are the 2 new basal insulins, relatively new, by Sanofi and Novo. And they are true basal insulins. And I have proactively taken every patient I had off of Lantus and put them on this because Lantus is not a 24-hour insulin. It was supposed to be, but in many type 1s that are totally dependent on exogenous insulin, it doesn't last 24 hours. Now, I'm not sure if some of you know about the InPen. It's a smart pen, really cool device. I had my UCSD clinic this week, and I think I put 3 patients on it if they wanted it. Right now, you can get it for $35. And what it is it's a non-disposable pen that holds your Humalog or Novolog 3cc cartridges, and you get a phone app, and everything you do is Bluetooth. It keeps track of all your doses, your correction doses. It sucks in the BGM and CGM data from Dexcom. It's cloud-based, and it gives you a really nice summary. So just like the summaries we get from people on insulin pumps, you know, when they download your pump data, it really is helpful. What percent basal bolus, things like that. So I think it's about time that people on multiple daily injections can have an app like this where you just put in your carbs, it gives you your suggested dose, you put in your blood sugar, it gives you your suggested dose there as well. And then here's just a slide on inhaled insulin. I mean, it's impressive how fast it works, but also how fast it gets out of your system. This is Novolog right here. So it's better postprandials and less delayed hypoglycemia. So, I don't want to get into all the details, but you can see the device is pretty small. I have some here if you want to see it. This is kind of a funny video. I was with my friend Jeremy. We were on a Southwest Airlines flight. This is, I was taking some inhaled insulin. Now, this lady against the window, she's reading a book. And I was a little self-conscious about taking out this little thing that looks like a reefer. And so, slide on the faster acting aspart. Some of you may not have heard about that. Folks from Novo made more rapid on, rapid off aspart, and you can see the difference in people who put it in this is a study of type 1s on a pump, and it doesn't peak as high. And I would say this, some people notice a difference, some patients don't. So it doesn't knock your socks off, but it is an improvement. And supposedly it's the same price. And you can put it in a pump too. So that's just to let you know what's present. There's just a picture of the two basal insulins, and they have a lot of benefits actually. And this is it. They have less intra-subject variability, meaning that, you know, even if you take Lantus or Levemir for that matter, you inject the same area every day and you measure, you know, how fast it appears in your blood and sticks around. It's different every day. They've shown less hypoglycemia. All the studies are against Lantus because that was the market leader. Less weight gain, flat, stable, prolonged action greater than 24 hours. Here's the thing I always tell people. This is important. If they try it and switch, it does take 4 to 5 days to reach equilibration. And if you don't tell someone that, they're going to think it doesn't work. When they come back and hey, this stuff doesn't work, I went back to my old regimen. They have to give more correction doses because it takes so many days. But once you reach equilibration, it's quite nice. Yeah, so they both have that. So this is just a picture of some of the studies. This is with TJO as an example. This is a glucose clamp study. But what they do is after 7 days of being on TJO, patients come in, they fast, they give them the same injection, and they measure how much glucose it takes to counteract the insulin. And you can see the glucose infusion rate is very flat. So that may be too much for you, but the bottom line is it works like the basal rate of an insulin pump. So, you know, I'm not going to talk about pumps much. We all know that the Animist has been discontinued, and there's choices. The T-Slim, I'll talk about the basal IQ, the control IQ, and then there's the tubeless pump, the Omnipod, which I use. I don't like tubing, but I always say this: make sure you pick the pump. You know, there are caregivers who shove one type of pump, and I don't think that's right. They're not wearing this pump every single day. I can tell you horror stories. They don't even tell patients the options. And I think if you're going to consider going on a pump, you should look at all the pumps on the market and make a decision yourself. So here's the T-Slim, the basal IQ. It's just an example of what we call sensor-augmented pumps. So here's, you know, I think anybody on the basal IQ probably, yeah, several of you. Yeah, when it communicates with a G6, and when it predicts you're going to get low, it turns off your insulin, and then it goes back on when it measures the rate of change that you're coming back up. So it's really just kind of the baby steps to the artificial pancreas. Now, the control IQ, which supposedly, and better time in range, they've shown that it improves your time in range in hypos, obviously hypos. The control IQ is very exciting. It's supposed to be approved before the end of the year. And it's just a software update, which is nice. And what it's going to be a hybrid closed loop. It's going to adjust your basal rate all the time, sort of like the Medtronic 670G, but you won't have to calibrate it because it uses the Dexcom. And it's supposed to have a more aggressive algorithm so that you can it helps with bolusing for small meals. So it's not a fully closed loop where you can just close your eyes and eat whatever you want. But it's supposed to be really, really good. I'm definitely going to try it. The Medtronic 670G, if you can survive on this, it takes a lot of work, a lot of calibration. It can do you well. This is a hybrid, this is a basal rate modulator. But it turns out that the research shows that only about 50% of people are still on it after 6 months, just because it takes a lot of work. I give them kudos. I give Medtronic kudos for coming out with the first FDA-approved one. So this is what I'm doing, and a lot of other people. Do it yourself, looping. This is what my phone app looks like. It's a basal rate modulator, and you can see this line right here. My basal rate is 0.65 units an hour, and here it's giving me more. You see that my blood sugar is going up, and here, right before that, it's giving me less. This is my blood sugar right here, 147. Don't think it's high, it just looks high. There's my goal, and then the very light dashed line is the predicted blood sugar. And if you're true with putting in data, like every time you have carbs, you got to put it in. Every time you give yourself, well, it keeps track of your boluses. It doesn't really keep track of my Afrezza. I wish they had a part of the app. It does a pretty good job predicting where you're going to go. So, for example, if my blood sugar was 147, and I just put in 1 unit as a correction, this dotted line changes right away. It takes it into the algorithm. And there's a lot of people on this. You have to carry around one of these little devices, and you can do it with an old Medtronic pump or an Omnipod. And I've had the best control I've ever had. There's no question about that. So a lot of people are on it. Anybody here looping? I know there's a couple of you. Yeah, got a couple of people. So this is like my 7-day average after I first went on it. You know, I mean, 80s, 92s, and 99% time in range. And we call, if you can go 24 hours, you get a no-hitter. I probably haven't had a week this good since then, but I was probably overly enthused. But I call it LLC, looping low carbs. I'm not a zero carb zealot, but I do try to watch the carbs in my diet. Now, there's a lot of companies. Yes.
What happens to you when you use the Afrezza on looping?
Well, my blood sugar comes down, but it throws the prediction off a little bit.
Yeah.
Yeah.
But you don't go low.
I hardly ever get low on Afrezza. And the thing is, I think, you would think that the algorithm would cause it, but because it measures your blood sugar, it accommodates for that. Yeah. So there's a lot of people working on the closed loop space. I mean, I'm saying this, if the looping people, these are the people with kids with type 1, they've had type 1, how come we don't have a full closed loop yet? Come on. The hybrid closed loop has been out for years. These guys must have flunked, technology classes. No, I don't say that. But now, why do they call it do-it-yourself? Because this is the lab of the first guy that put it together. Do you believe that? That's just a joke. I got that off the internet. So basically, a lot of people say it's a personal choice. NDI, I do think, and I have a prediction that once these, like the Control IQ, the next Medtronic system, hopefully, looping, I do think that it makes these systems way more attractive than multiple daily injections. Now, I want to go back to Bigfoot, which is right here. Some of you know about Bigfoot. It's run by Jeffrey Brewer, really smart guy, has a son with type 1 that developed brain damage from a bad low. He used to run the JDRF, super smart, and he purchased the old Asante insulin pump and supposed to be partnering with Abbott and developing a closed loop system, not only for people on pumps, but people on smart pens, like the end pen I showed you. Now, how's that going to work? I don't know. I'd imagine if you're on a multiple daily injection regimen, it'll tell you give 2 units now. And if you don't do it, it's not totally automatic. So I don't know how that's going to work. And there was a recent announcement that they're kind of giving up on their pump, and they're just going to work on a multiple daily injection closed loop system. I just don't know how that's going to work. But knowing Jeff, I wouldn't be surprised if it worked pretty well. So, you look at guys, the team type 1 guys from Novo Nordisk, my friend Phil Sutherland, these guys all have type 1. They're riding bikes for 7-8 hours at a time. And there's just no way they could not do it without modern technology. There's Brandon Morrow. He used to be on the Padres, professional pitcher. We all know Charlie Kimball, Indy race car driver. And I just got a Peloton, and I've heard that this instructor has type 1. And I've never taken a class from her yet, but anybody have a Peloton here? Okay, good. Yeah, they're good. They're really good. And this is Chris Freeman. He is an Olympic cross-country skier. I don't know if you remember the story, but one Olympic, he didn't believe in CGM. He didn't wear it. He said he didn't need it. He got low during the races. He got disoriented mentally, he went off track, and he got disqualified. Now he's a spokesperson for Dexcom. And so there's just no way. Look at those abs. You want to see my abs? It's so funny. Okay, almost done. Let's talk about the future. Westworld. I'm not that crazy about that show, but it is about the future. A lot of people like it. You know, we know that type 1's an autoimmune disease. These killer T cells, they're specifically directed towards the beta cell. And I always look at the brighter side of things. I'm kind of a glass half full person. I mean, it could have knocked out the delta cells, the alpha cells, glucagon, somatostatin. It could have knocked out the exocrine portion of the pancreas. That's where there's a portion of your pancreas that secretes digestive enzymes. So for people who have their pancreas taken out, they got to take 2 or 3 digestive enzyme pills before every meal. And so it's amazing that you develop these antibodies super specific for one cell and one cell only. You know, type 1s get other autoimmune conditions, hypothyroidism, but that's the cause of the disease. We don't know what causes that, but we do know that's the cause of the disease. And so we just don't know what causes this. And there's been lots of theories, but to be honest, none of them have come to fruition with human studies. They have cured 300, in 300 studies, they've cured diabetic mice, diabetic rats, and then there's lots of hoopla. Everyone puts out their press releases, and then it's a failure in humans. That really bugs me. And there's a whole bunch of people out there that say, no, don't waste clinical research dollars on animal studies. Now, here's what I wanted to tell you about. This was recent. This was probably less than 6 months ago. Teplizumab. It's a monoclonal anti-CD3 medication antibody. That what they did was, this is part of TrialNet. I think that was the TrialNet. That's the government organization, that's the warehouse for type 1 studies. They measured antibodies in a group of people to screen. So they took all these people destined to get type 1. Half of they gave placebo, half they gave teplizumab. Teplizumab, I have a hard time with this. So it turns out that it delayed the onset of type 1 by 2 years. And that was really the first human study that showed a benefit. So I think that's huge. You know, we're not going to cure type 1 overnight, but I think that's a pretty important baby step. Now, if you have a kid that's, say, 5 years old that comes down with type 1, would you like to give them 2 more years? Because look what's going to develop in the next 2 years. Maybe those 2 years they'll have a fully functioning artificial pancreas.